All right. So for those of you who don't know me, my name is Gina. I'm going to be doing a talk on nutrition in the critically ill today. When I was assigned this topic, I remember saying, wow, that's a huge, I mean, that's like a whole subspecialty. Why am I assigned nutrition in the critically ill? Can we narrow this down a little bit more? And I also was feeling a little bit bored. Nutrition to me was never or hasn't been a sexy topic, and just as you probably feel I'm going to get my phone out and start texting because I don't really care about this, I also took my phone out and started texting when I was assigned this as a project. And I said, nutrition is so boring. I had several conversations with colleagues that you may recognize. Basically,
I didn't know this was public.
I know. I told Jana. I said I should get your permission. Realizing or I guess drawing attention to how boring I thought nutrition was. But then I don't know if it was the Bader-Meinhof effect or the fact that, I needed to make myself interested in what I was talking about. I started looking around my house and I realized that there was a lot of things in my house that were focused on nutrition. I have a whole shelf in one of my cupboards that's just protein supplements. And I clearly like nutrition for myself as a healthy person. So if I'm interested in myself as a healthy human being, why am I not so interested in it as in delivery to my critically ill patients? And how can I change that? Now, there was a physician named Dr. Berger who wrote in one of his many essays on nutrition was the reason that physicians may not be, or healthcare providers may not be as interested in nutrition in the critically ill is because we don't see the side effects of it immediately. If you walk into a patient's room and they're statting 75%, if they're not intubated, maybe you're going to make a decision to intubate them. Or if they are intubated, maybe you're going up on their PEEP and their FiO2 because the deleterious effects of that hypoxemia is present immediately. When it comes to nutrition, the deleterious effects aren't seen as early, and thus we tend to forget about them or not necessarily be as cognizant of them. My goal during this lecture is that we will be cognizant of them and that we'll learn that nutrition is something that's important. Oftentimes we won't see it until 7, 10, 14 days after a patient's been hospitalized, but it makes a huge impact in their life. Over the course of this lecture, my hope is that you'll be able to understand the critical role of nutrition therapy, that you'll be able to command a good knowledge of benefits of enteral feeding, discriminate patients that are at high risk of malnutrition, and that you'll also be able to determine when TPN should be employed, and then maybe obtain some tools to help optimize your patient outcomes. So before we step into discussing enteral feeds and malnutrition and all of that, let's talk a little bit about normal metabolism. So our body is taking in fuels and using fuels on a regular basis. You guys all have various proportions of carbs, fats, proteins on the plates in front of you right now. And your body is taking those in because as we breathe, as our neurons fire, as our muscles flex, our body is doing work. And that work is provided by these organic fuels. If you remember back to med school, the oxidative phosphorylation that we undergo to produce ATP and CO2. And this is something that's done on a daily basis without you or me thinking much about it. Our body's energy expenditure is replaced by the nutrients we require, and we consume oxygen, spit out CO2, and we don't think about it. But there's a big difference from somebody who's power walking on the beach and their metabolism than the person who's laying in the ICU bed. And what happens? So when the body's exposed to a stressor, there's a lot that occurs. The sympathetic nervous system is stimulated. The HPA axis releases cortisol, catecholamine surge, and there's a significant effect on the inflammatory and immune system. We see this in another cartoon here, showing that in the setting of significant stress, the body is increasing gluconeogenesis, lipolysis, protein catabolism, and causing a hypercatabolic state. This was proposed by a physician named Dr. Cuthbertson in 1930, and if you've worked with Dr. Rivers, he talks about the ebb and flow frequently of patients' metabolism. Within the first 12 to 48 hours of critical illness, patients are in this ebb phase where they have a decrease in their basal metabolism and their energy requirements aren't as much. However, in that, 24-hour, 7-10 days of critical illness, they're in this flow phase where there's a major protein catabolism and the amino acid pool, glutamine, are being used significantly. What this really comes down to is that critical illness causes a state of uncontrolled metabolism and significant resistance to anabolic signals. The reason that it's important is because malnutrition in the ICU is significant. Patients come in malnourished, and in addition to that, the development of malnutrition increases our patients' risk of mortality, length of stay, infection, readmission to the ICU, and discharge to skilled nursing facilities. All of this being said, this is a significant burden on us as physicians as well as the healthcare system at large. Patients with normal nutrition that are being provided nutrition still have a significant lean body mass loss during their ICU stay, and if we can avoid worsening this, the better it is. So what are our goals of nutrition therapy? The goals of our nutrition therapy should be A, to attenuate stress, B, reduce oxidative injury, and C, improve immune response. This will allow us to preserve muscle mass, maintain our gut function, improve wound healing, decrease infection, and help, as I mentioned before, reduce the morbidity, mortality, and healthcare burden that this has on our society. So then this opens a whole can of worms. Well, you're telling me nutrition therapy is good. What do you mean by that? Is that like IV nutrition, enteral nutrition, how much nutrition, when do I start nutrition? And this is why there's whole subspecialties and societies that are aimed at nutrition therapy. Now, I think there are a couple tools, though, and a couple pieces of information that everybody should be very familiar with. And we're going to answer some of these questions over the course of this lecture. Now, the first question that arises is, how should I feed my patient? And you may have heard, very early on in your medical careers as the medical students, if the gut works, use it. Why? Well, what happens when the patient has bowel rest is that the mucosa of the small bowel begins to atrophy. You lose the height of the villi, the tight junctions become loose, and providing a patient, even with a small amount of enteric feeds, maintains the functional and structural integrity of your gut. This allows the tight junctions to remain. This allows the immune defenses of the gut to remain intact and helps prevent bacterial translocation. Additionally, compared to parenteral nutrition, enteral nutrition has found to have a lower risk of infection because parenteral nutrition is often seen to impair cellular and humoral defense. So enteral nutrition is not just, use the gut because it's easy and because it's there, but because it's an infection control measure. So let's answer some of our other questions by looking at a case. So you have a 77-year-old female. She has a history of CKD, diabetes, hypertension, and heart failure. She's admitted to the intensive care unit for worsening renal failure. She's volume overloaded. She's on BiPAP. Now you're at day 2. She's diuresed. You're not really requiring BiPAP anymore, but she's a little bit encephalopathic, and she's really only picking at the trays that you're giving her. On quality rounds, you begin to discuss her intake, and the nutritionist suggests starting her on feeds. You're prompted with this question, and you're going to reply with one of the following. A, just let her eat what she can. Even hospital food is better than an NG tube. B, sure, Alex. Tube feeding sounds excellent. C, I'm not quite sure. Let me look into her case. Or D, with silence. And I think all of these answers have been given at some point in time. Now, what I want to do is focus on C. I'm not sure. Let's look into her case. Because I think that's where most of us would, do I really want to start this, put an NG tube on? She's a little encephalopathic. What if she pulls it out? Are we going to have more issues? Is there anything about this patient that suggests maybe she would benefit from having early enteral feeds? In order to determine this, we have to calculate our patient's nutrition risk. A nutrition risk is the risk of developing adverse events or complications in the setting of a patient who does not have adequate nutrition. This is predicted by premorbid disease or disease severity, and this can be estimated by two different scoring systems that are both recommended by the Society of Critical Care Medicine. There's the NRS 2002 and there's the Nutrix score, and I'm going to show them both of them to you guys today. So first of all, the NRS 2002 score looks at two columns: impaired nutritional status and severity of disease. So you pick one from each category, or one box from each category as far as where your patient lives. If they have mild impaired nutritional status, moderate, or severe, and then severity of disease where they're at. Interestingly enough, an Apache score greater than 10 gives you a score of 3. I would argue that the majority of our patients that are in the intensive care unit probably have an Apache score of 10, or they wouldn't be there, which already puts them at nutritional risk. They get an additional point if they're over the age of 70, and then based on what they're taking in or what their baseline BMI is, then you'll be able to determine if they're high risk, meaning will they benefit from early enteral nutrition. The difficulty with using the NRS score is the fact that we often don't know what the patient's baseline is. I don't know what they've been doing over the past, 2 months. Have they lost less than 5 or more than 5% of their body mass? How am I supposed to know? That's something that's difficult for us to obtain. So there's a Nutrix score that was created to look at the values you actually have while the patient's in the hospital to determine the same thing. Will my patient benefit from early enteral nutrition? That means starting tube feeds within 24 to 48 hours of their arrival. This patient, or in this scoring system, we see that patients are at high risk of developing adverse outcomes from delaying nutrition if they have a score greater than 5. An age greater than 75 automatically gives you 2 points, an Apache score that's elevated, SOFA score that's elevated, and then the number of comorbidities and length of stay also contribute to that. Now, some of you may say, well, we never check an interleukin-6. How reliable is that? They've validated this score even in the absence of IL-6, so just looking at the first 5 variables is still valid. So if we look at these, our patient clearly is positive here because she's 77, she's got a Apache score of greater, or she's got an Apache score greater than 10, so she's already at 4. And I'm sure if we calculated where she was previously, we might get up to 5. Here, definitely just based on her number of comorbidities, age, and days from hospital ICU admit, she is at high risk for malnutrition and would benefit from starting early enteral feeds. In addition to just maintaining gut integrity, we also can see that early enteral feeds have been shown to decrease mortality and decrease infectious morbidity. So there's really no reason not to start her on enteral feeds at this point in time. So you determine she's at high enteral or at risk, and you place a DOPHOF and you start enteral nutrition. Next day the nurse calls you and says, the intern forgot to put in a goal rate for feeds, and I just want to know what the target rate is so I can get this patient up. If you're Jackie, you'll probably say, I'm placing a Blakemore right now. Can you call the intern based on her month? A very common reply, keep it at 20 cc's and see what nutrition recommends. Give me a second, I'll calculate it. Who's doing that? No one. 42? Or do we have a spare metabolic cart? Now, I think more than one of these answers are correct in that, we can see what nutrition calculates, or we could calculate it ourselves. Metabolic carts, actually, though, are potentially the most useful in determining energy expenditure. And the reason is that over the course of our severity of illness, we have differing energy expenditure. We already talked about the ebb phase and how early on our basal metabolism decreases for a period of time, and then we have this hypercatabolic state. So from a day-to-day, even hour-to-hour basis, the energy expenditure by our patient is fluctuating. It's recommended by gold standard to monitor this energy expenditure by indirect calorimetry. So I hook up a patient to a metabolic cart, I see how much oxygen they're consuming, I see how much carbon dioxide they're putting out, and I calculate how much their energy expenditure is. But how many of you have ever used a metabolic cart? Dr. Rivers isn't raising his hand, but I'm sure I know he has. And Rodeo, and I'm sure Dr. Field has been involved in a couple things with the metabolic cart, but it's rare. We rarely use metabolic carts, and the reason is they're expensive. We don't have a whole lot of use for them. And, you know, people argue that they're complex because if you have a patient that has an FiO2 requirement higher than 60%, if they're on dialysis, all of these things can impair the usefulness of a metabolic cart. So then we say, do we have any equation we can use to predict how much our patients are expending energy? And we do. We have a lot of equations to predict how much energy our patients expending. But they're not really good. The most accurate is the Harris-Benedict equation, which I'm not going to go through what the equations actually are, but that equation was accurate only to 61% when compared with indirect calorimetry. And the ACCP guidelines, which are also the SCCM guidelines for goal feeding, are 43% accurate. They underpredict significantly and also overpredict significantly. And so using these guidelines, our patients kind of get like some random amount of food that we don't know if it's useful or not. This is a very significant thing because overfeeding is a big risk for our patients just as much as underfeeding is a big risk for our patients. So let's talk about overfeeding. There are significant consequences to overfeeding your patient. High parenteral caloric intake has been shown to be an independent risk factor for bloodstream infections. This was seen in the days of hyperalimentation when patients were started on, TPN and just given a ton of glucose. They would get hyperglycemic and they develop bloodstream infection. In addition, giving patients a lot of food leads to hepatic steatosis, cholestasis, and increases your risk for acalculous cholecystitis. You're basically turning your patient into the duck who's going to be foie gras. I don't know how to say it properly. In addition, high carb intake leads to hyperglycemia, increases lipogenesis, and then increases CO2 production, potentially making it difficult for you to wean your patients from the vent. This consequence of overfeeding can be seen at rates as low as 27 kilocalories per kilo per day, which is only 2 kilocalories per kilogram higher than the recommended by ACCP. I would argue, though, that overfeeding is not as big of a risk as underfeeding in our patients. Underfeeding in our patients also shows an increased risk of infection. It increases rates of bloodstream infection in patients with less than 25% of their goal enteral nutrition. Arguably increases mortality depending on which study you read. Some people say it's neutral, some people say it's positive, and there's multiple studies showing that it has increased complications, including ARDS, sepsis, acute renal failure, and increasing pressure sores. Now, how little is too little? Some argue less than 25%, but there's been studies that have reproduced that any less than 50% of the nutritional needs, patients tend to do worse. So is there benefit to targeting nutrition particularly? So if I can say, I'm going to give my patients the exact amount they need, do they do better? There was a study looking at this called the Takakos study, looking at tight calorie control, and they basically hooked up patients to indirect calorimetry and said, I'm going to give you the calories you need based on the amount that you're expending that I'm calculating on a daily basis. And then I'm going to compare that to the group that just gets the control SCCM guidelines or ACCP guidelines. Comparing those two, they found, interestingly, that the control group, getting only 25 kilocalories per kilo per day, had actually higher caloric debt, which is interesting because the accuracy is so off in the ACCP, but they tended towards having a higher caloric debt. Those that had indirect calorimetry directed nutrition had appropriate amounts, and what they found was patients that had higher caloric debt had increased ICU length of stay, increased vent days, increased infection rate, and a trend towards VAP and a trend towards mortality. So it continues to show, like we saw with these consequences of underfeeding, that patients that have caloric debt do poorly. Anywhere between, you can see these findings at a caloric debt of only 4,000 kilocalories during their ICU stay, which is like 2 days without eating. So this is a very important thing that we need to be aware of. So how can we avoid this? It's easy to say, oh, well, my patient's too sick, I can't feed them, or whatever, excuse that you want to make. But there's things that we can do to avoid caloric debt. First of all, limiting our NPO status on our patients. Studies have shown that more than 85% of patients are NPO between 10 and 20% of their ICU stays. So I know that's a lot of percentages, but basically, if you're a patient in the ICU, what that means is 20% of the time you could be getting food and you're not. And that is leading to your caloric debt. 20 to 60% of that population that's missing out on that infusion time, all of that could be waylaid by saying, okay, well, maybe I'm going to, be more appropriate with my NPO order, making them NPO, only 8 hours before I know the time that their procedure is scheduled rather than at midnight, or whatever change you want to make sure that you're limiting the time that they're NPO. Gastric residual volumes are another thing. They're actually one of the quoted to be the main factor in interrupting enteral nutrition during an ICU stay, other than limiting your NPO. Gastric residual volumes, also checking them, reduces your time to getting to a therapeutic dose of enteral nutrition. So because your patients are because your nurses are stopping feedings and checking their gastric residual volumes, the patients are less likely to get to goal rate as quickly as they need to. If you look at the guidelines, though, by Aspen, I know we check gastric residual volumes here frequently, they recommend against routine gastric residual volumes. And the reason is that gastric residual volumes vary hugely between patient to patient. It varies by the patient's position, the location of the feeding tube, if it's post-pyloric or pyloric, if the patient has, the syringe size that they're using, the method they're using, if the bore of the feeding tube is bigger, then the amount of gastric residual volume is higher. So really, it's not a good measurement. They compared using different, if you're really hell-bent on using gastric residual volumes, and they said, well, if you're going to use a gastric residual volume, can you at least increase your threshold? So rather than stopping your tube feeds at 250, can you increase it to 500? And they saw that there was no increased risk in pneumonia, no increased risk of aspiration, and maybe, I think there was one patient between the two groups that vomited with the higher gastric residual volume. So very minimal risks of either avoiding gastric residual volumes altogether, or at least saying I'm not going to stop them until my gastric residual volume is greater than 500 mLs. Other considerations that have been raised to avoid caloric debt is considering a 24-hour volume goal. So you have that patient that you kept NPO for 12 hours. Maybe doubling their tube feed rate for the next 12 hours is not bad, so they can get to that 2,000 kilocalories that they need per day. They've shown that patients that have isogenic or isocaloric intake do better, so why not give our patients the calories they need? Other considerations is supplemental parenteral nutrition. Now this one was something that was new to me because it's never something that I've been familiar with, and I don't know how often you guys in the surgical ICU use supplemental parenteral nutrition. I think it's more common than we do, but using TPN to assist your patient's nutrition requirements. So there was a study done in Switzerland looking at patients that couldn't reach their enteral nutrition goal. And they said if they couldn't get to, we know early TPN is bad in our patients, so if we can't get to their enteral nutrition goal of greater than 60% then by day 4, then we're going to start them on supplemental nutrition to make up for that caloric deficit. What they saw was that isoenergetic feeding, not surprisingly, reduced nosocomial infections. So patients that don't have caloric deficits don't get infected. Additionally, in avoiding caloric debt, also just be cognizant of what your patient's getting. So if they're getting D5 and they're getting antibiotics in D5, then understanding how much kilocalories that they're getting per liter. In each liter of D5, there's about 200 calories. And when your patients are on propofol, they're getting about 1 calorie for every ml of propofol they're consuming a day. So when you're calculating these, not only are you able to avoid caloric debt by making sure that you know what your patient could be getting, but also understanding what your patient is getting. So what we've learned in summary is that caloric deficits are harmful. Starting feeds early, getting to goal quickly, avoiding interruption of tube feeds, reassessing needs frequently, and starting TPN when needed is important. Now, I mentioned starting TPN when needed, and you are probably thinking, well, we didn't talk about TPN. So that's what's next. And now we're not going to talk a lot about TPN because I don't think there's a whole trend to using TPN, but there are important reasons to start parenteral nutrition. One, we already talked about, is if the patient's at high nutritional risk. We're going to address that in a minute, but just so you know, the reason that we don't use parenteral nutrition is that patients that have early parenteral nutrition have increased morbidity compared to those who don't. But this was looked at in a population of low nutritional risk. So we are comfortable saying, oh, patient, if Jackie, for heaven forbid, got intubated for respiratory failure, she's like a healthy person. She has low nutritional risk, and she may have moderate, depending, I don't know what sort of past medical history you have. But as far as I know, you could probably go okay for a week being NPO if something was wrong with your gut. However, if your patients have high nutritional risk, they're at increased mortality if you're not feeding their gut. So if there's some horrible contraindication like discontinuity or some such that you're unable to feed your patient enteral nutrition and they're at high nutritional risk, they should get tube feeds. Why? Because patients that are not fed compared to patients that are parenterally fed have an increased mortality by a factor of 3 times. So you have a patient coming into your ICU, a transfer from an outside hospital, who's had multiple abdominal surgeries and has persistent respiratory failure and currently has a bowel that's in discontinuity and is not able to get enterally fed. Start them on TPN if they're not on TPN already, because you're reducing that caloric deficit. Now, there's many other considerations during nutrition. Now, as far as fine-tuning nutrition, there's thoughts on initiating dietary antioxidants, whether fish oils are beneficial, trace elements, pharmaconutrition. Those are not things that I really want to spend a whole lot of time discussing today. But understand that there's a lot of fine details that you can adjust and address when managing your patients. In conclusion, things you need to know. Nutrition is about energy provision, and it's about infection prevention. Your role as a provider is to identify high-risk patients and to be able to ensure that they're receiving their needs on a daily basis. Thank you for your time. Any questions? Yeah.
I'm sorry I missed the first 10 minutes.
Oh, no.
Is there anything to differentiate those with high BMI from those with suboptimal BMI?
So,
What's the relation of obesity